While the USA has long grappled with rising chronic illnesses, a similar trend is now unfolding across Africa and other regions where infectious diseases once dominated. On The Future of Medicine, we explore solutions with Dr. Baxter Montgomery. A leading cardiologist, Dr. Montgomery uses integrative nutritional therapy to revolutionize healthcare. Let's delve into his transformative approach.
It's a pleasure to be in your conference, and it's always a pleasure to share knowledge with anyone who's willing to seek it regarding natural health. I made a quick note here in your intro. Africa, the continent of Africa is about to receive its largest increase in non-communicable deaths this year. So that was an eye-opener for me because of course, we are used to dying from non-communicable causes here in the United States. And I'll share a lot of that data with you in my conversation. I'm going to get right to my presentation. I'm going to share my screen and someone just give me a thumbs up or something, let me know that you can see my screen pretty well. I've done some of these talks before and I've gotten a third of the way through them and said, we can't see your screen. But anyway, the topic today is going to be that on integrative health. And I think it's the future of medicine here in the West and perhaps worldwide. And integrative health is an approach that we have been using in Montgomery Heart and Wellness probably for the last better than decade or two, largely because we've been in a health crisis for a long time. And I think it's been amplified in the last 2 years. This graph here shows you life expectancy in the US, and we've reached an all-time low in the 21st century. And if you notice, from 1995, there's been pretty much a steady increase, maybe a few plateaus here and there. In 2014, for the first time, there was a significant dip in lifetime expectancy from 2014 to 2015. There was a bit of a plateau after that, maybe another dip. So there was a slight decline from 2014 to around 2016 in life expectancy. There was then an increase after a while here, maybe back to where we were in 2014 and 2019. However, then there was a steep drop from 2019 to 2020. Now, of course, the COVID pandemic did not hit in 2019, so we certainly cannot blame it on that. Then there was another steep drop from 2019 to 2021. I'm sorry, 2020 to 2021. And we don't have the data in from 2021 to 22. Excuse me, 22 to 20. 21 to 22 data is not in. I've looked it up recently. However, some people speculate that it's still maybe going down. So this is a very steep drop in life expectancy here in the United States. And the vast majority of it is due to cardiovascular disease, which I'll go through in a minute. But the big problem we suffer from here is that sickness has become the norm. And so starting with cardiovascular disease, in 2019, we had about 874,000 deaths, almost 875,000 deaths just from cardiovascular disease alone. To put that in some level of perspective, in 2020, globally, there were probably 19 million people who died from cardiovascular disease compared to only about 6.73 million people who died globally from COVID. That's about 35% of the cardiovascular disease deaths. So despite how horrific COVID was, it paled in condition to the annual pandemic we have with cardiovascular disease. From 2015 to 2018 in the United States, Black men and women are about 60% prevalent from cardiovascular disease. Is the highest race prevalence that we have here in the United States. There's some biological reasons for that. And the top causes under cardiovascular disease, as we know, are coronary heart disease, which is very prevalent here. Other forms of cardiovascular disease, there's stroke, there's high blood pressure, heart failure, and other diseases of the arteries. This slide I use to give some perspective. So this slide gives the number of people who died in all the different wars, all the American soldiers who've died in the different wars over the years. So you start with the American Civil War, roughly 620,000 people. Some people may dispute this number, it may be 700,000, but roughly 620,000 men, U.S. soldiers died in the Civil War, the greatest loss we've had. World War II is second to that. But every year, as you can tell, we have more deaths from cardiovascular disease than we had deaths in the Civil War. So it's almost like just with cardiovascular disease alone, we're fighting and losing men to this war every year. But then if you add cancer to it, so cancer in the US causes roughly 600,000 deaths. So cancer and cardiovascular disease combined, you see somewhere around 1.4 million deaths. And this is roughly every year. And you compare that to all the deaths of every soldier we lost in all the wars in the United States history. That's roughly about 1.3 million. So in essence, cancer and cardiovascular disease combined cause more US deaths each year than we've lost all the US soldier deaths in the history of the United States. So it's almost like we're fighting every war and losing all those deaths every year just with cardiovascular disease and cancer alone. So it's pretty costly. And the unfortunate part about it is something that it goes unnoticed. So we were having a major war here in the United States and we had 600,000 deaths. It'd probably be hard to cover that up, but it seems like the cancer deaths and heart disease deaths here in the States is something that goes unnoticed, or at least is accepted as the norm. It's amazing cost to us. It was a roughly 10% increase in costs in 2020. The public health spending more than double in 2020 for chronic illnesses. The health expenditure by our federal government is about 36%. It's the largest pusher of our debt. The government share increase, we spent about $12,500 per person here in the United States in 2019. And so it's a huge burden on us economically as a country. And of course, individuals, a huge burden because the number one cause for bankruptcy, the last time I checked, was bankruptcy from medical bills. So it's a major problem financially as well. So needless to say, we need a paradigm shift. And so this is something that we've been promoting in our center and of course in the talks that I've done over the years. And lifestyle intervention really needs to be the first and foremost intervention. Lifestyle intervention should be the first line of treatment of choice for prevention, control, and reversal of all chronic illnesses. Now, we say in the West, the Western medicine is great for acute illness. Certainly if you break your leg in a motor vehicle accident and some trauma event, we have excellent care for that, and it's probably second to none. Maybe even acute exacerbation of chronic illnesses, acute heart attacks or acute exacerbation of lung diseases, we do extremely well. However, even in many of those conditions, lifestyle intervention plays a critical role. I've personally taken care of patients in the throes of a heart attack, acute decompensated heart failure, and we've had to treat them with a lifestyle intervention because they were too sick for the surgeries or interventions or the like, and they actually turned around and did well. So I'll share some of those examples with you in my presentation. So lifestyle intervention isn't something only for prevention. It is a very, very powerful intervention, even in the acute setting. And at the very least, it should be an adjunct to anything else that's done for a patient who's acutely ill. So what I want to do, the next series of slides, is talk about our nutritional medical integration. I want to share with you some of the nuts and bolts of what we do when we evaluate patients in our clinic. So as an overview, I want to talk about our clinical assessment of the patients, how we deal with that, nutritional wellness assessment. We're going to talk about some of the integrative therapeutic interventions. We've added some interventions since I've made some of these slides. We'll talk about our clinical follow-up, which is very important. And then we'll share some of our data. We've scientifically validated a lot of what we've done. And then we'll deal with some clinical cases as well. So when a patient comes to see us, typically, they'll come in with, a complaint of one or more chronic illnesses. We typically follow the standard medical approach. We take a history and physical exam. And this is really important, especially the history part, because this gives me a chance to visit with the patient, get to know the patient as a human being. We have a team approach to this. We have a medical assistant that'll come in and do the vitals and do that assessment. I have 2 mid-level practitioners, one a nurse practitioner, one a PA, who will then see them either along with me or before I see them. And then I will see them and we'll discuss a care plan. But the history and physical is important because it gives us insight in terms of what the patient's concerns are, what the illness is. It allows us, it gives us about 85–95% chance of making a diagnosis. And so this is important. If we do well here, then the rest of this becomes pretty straightforward. We do extensive biomarker testing. We may draw as many as 15 tubes of blood. We get inflammatory markers. Sometimes we even do extra tests that are send out labs to give us insight, biochemical analyses, and the like. There's non-invasive testing we do right in our office, echocardiograms, vascular studies. And if need be, we'll send them to the hospital and do invasive testing. I used to do coronary angiograms, electrophysiological testing, and the like. And so we cover the spectrum, and if a patient needs to be admitted, they're under our care. We don't transfer their care to anyone else. So the integrative therapeutic intervention in concept is a comprehensive medical intervention, and it's initiated along with a nutritional detox or other nutritional plans. So when someone comes in and say, I have high blood pressure and say diabetes, I have arthritis, we'll review all their medications, and we'll have patients with maybe 26 medications or 10 medications, whatever the case may be. And we'll look at that, and we may make changes in the medications. Sometimes on day one, we can see medications that are unnecessary. So we may consider making changes. If they've taken a lot of over-the-counter supplements we're not certain about, we'll make those changes. And medication changes and medication weaning is a very, very important point, part of our intervention, because we often see adverse effects of medications being a contributing factor to the person's ailment. So for example, I recall a patient coming in and they were on a statin drug, and they had musculoskeletal problems and muscle aches and pains, and they were taking 2 other medications for that. And so we started them on a nutritional detox. They were doing well. I stopped the statin drug, and those symptoms went away. We were able to not only stop the statin drug, but also the medications used to treat the side effects of the statin drugs. And so, that's one example in terms of how medication weaning can actually help the patient. In the United States, we have categorized heart disease, number 1 cause of sickness and death. That's number 1. Number 2 is cancer, but number 3 is medical treatment. And so that's something that, we have to be on top of and be mindful of here in the United States, because it's very, very common for people to come in on multiple medications, and that's contributing greatly to their ailments. So then we start off with an initial food prescription. Typically, they'll meet with our nutritionists, or either sometimes I'll outline some things for them. And it depends on how detailed we need to get. Sometimes patients are so busy with their diagnostic tests on day one, we'll give them a brief overview and schedule them to come back in like our integrated care clinic, where we can focus more on nutrition. But either way, we go over the details of a nutritional plan. We review that in the context of the foods they already eat, and we try to evaluate the goals they have and the like, so we can put together something that works very well for them. And then if needed, there's minimally and non-invasive medical treatments. Some patients we've had patients come in with severe congestive heart failure, arrhythmias or the like. We may give intravenous furosemide or other fluids. Some patients are volume depleted. We may give intravenous saline. So we can do a moderate number of minimally invasive things to prevent them from going to the emergency room. If they are sick enough, we may have to admit them to the emergency room. We've had patients come in. One patient came in, and actually he wasn't a patient that day. He was visiting our restaurant, which is open to the public. And I was just passing through it because it's within our facility. And he said hello to me and said, "Hey, I intend to be a patient of yours one day." And I said, "Oh, great. We look forward to seeing you." And I went back to the clinic side, and it wasn't long after that that someone was banging on the clinic door saying a patient passed out, and it was this gentleman. We ended up having to admit him to the hospital. So sometimes we get patients that's come in, in all sorts of conditions. We've had people come in with acute cardiac arrest. We've had to resuscitate. So I say all that to say this: we cover the full spectrum of what the patient's needs are, and we try to, treat them in the acute setting to the extent we need to, but work and transition them away to where they're not requiring these medications and acute treatments. Now, excuse the busyness of the slide. Large part I have it here so you can go back and reference it. But what I want to show or demonstrate with this slide is that we have a medication assessment and optimization and weaning protocol. So we don't wean medications on a random approach. There's a standard baseline medication changes. There's an approach to week 1, week 2, week 3. Now, this is generally a guide. Obviously, we have to modify that with time, depending on what we do. But this just gives you an idea of the approach we take and the order in which we may wean medications. Now, the food prescription overview. First of all, I like to use phrases like food prescription. It's not a diet. It's really a lifestyle change. But even in the context of what we use, how we use nutrition in a prescriptive approach. So what do I mean by that? There's a certain level of precision that one has to have. So oftentimes you can say, well, you need to cut back on sweets or cut back on animal protein, just follow a vegan diet or do this. And really, that's not enough. Patients really need to have very precise direction in terms of what to do and how to do it. Not from the standpoint of them understanding it, but if someone is critically ill, let's say they have a congestive heart failure, and maybe they're on an infusion of milrinone or they have an LVAD. So this person is in very, very unstable territory. So we have to put them on a very defined and precise nutritional detox regimen. They need to know to stay on that for a certain period of time while we're making adjustments in their medications and the like. And so it's very critical for us to be very precise in what the patient eats. A deviation of a meal, one bite, drop a crumb can send a patient to the emergency room in the ICU. And I say that not just to be cute, but really this is just based on experience. When patients deviate just a very small amount, especially if they're very critically ill, then many of them don't have the reserve to recover. Now, that doesn't necessarily apply to a large number of people who, don't have these issues, large because maybe they have hypertension, high cholesterol, and they have a lot of reserves. So they may deviate a little bit, not that we encourage it, but they're not as critical as some other people with systemic inflammatory conditions or a systemic heart failure, in which case they have very, very minimal reserve. So anyway, the general concepts that are of the food prescription is to define manipulation of nutrition. I think that's important. If I have someone on a raw detox, a cold pressed juice feast, time restricted eating, that's not meant for life, but we're manipulating what they remove from the diet to bring about certain biochemical changes. And again, the basic objectives that we're looking for, typically we're trying to reduce inflammation and oxidative stress very quickly. Oftentimes there may be other objectives. And the general experience is that basically the efficacy of this has been scientifically validated in peer-reviewed journals, and we are constantly optimizing our approach. Here's another busy slide. I'm not going to go through the details of this, but I like to show this slide, and you can reference it later because we do have a food prescription nomenclature that we frequently use. So position 1 denotes the duration of feasting hours. Position 2 denotes the duration of fasting hours. Position 3 denotes days of intermittent fasting if they have it. Position 4 denotes days of complete fasting. Position 5 denotes food level consumed during the feasting period. So if somebody's on a 4-20, 5-2, parentheses 0 to 4b, they are feasting for 4 hours a day. They're fasting for 20 hours a day, and they have an intermittent fasting, like a 24-hour fasting days, 2 days in a week, okay? And then the foods they consume are food levels 0 to 4b, which I'll mention briefly what the food classification system is. So this person is feasting or eating for 4 hours. 20 hours during the day, they're drinking water. they're doing that for 5 days. So 5 days, they're feasting for 4 hours, fasting for 20 hours. And they do it, but 2 days, they're fasting for 2 days straight, 24 hours. So these 2 days is nothing but water. So this is a 2-day water fast with a 420 time restricted eating period for 5 days. And when they are eating, they're consuming foods from 0 to 4B. 4B foods are dehydrated raw foods. Zero is like liquidated raw juices, cold pressed juices, smoothies. 1 through 3 are solid raw foods that are not dehydrated. 4A are high fat raw foods. And I'll go through a little bit of that later. This person, they're on a 427-0. So they're feasting for 4 hours, fasting for 20 hours. That's water only, water and sleep. And they're doing that for 7 days a week. And there are no days of 100% water fasting. And they're doing level 0. So they're just doing smoothies and cold pressed juices. So there's some nomenclature that we use in our prescription approach. Minimally invasive treatments, vein ablation therapies, we've done lymphedema therapy, we've accommodate implantable cardiac monitors we've done over the years, intravenous infusions, vitamin infusions. We now do ozone infusions, medication injections, intramuscular supplement injections. So we do these things in our facility. We're 4 miles south of the Texas Medical Center. I practice at one of the large hospitals there. So if our patients need to be admitted, they'll be admitted under my service, and I manage them in the hospital. We do general hospital admissions. Now, I stopped doing procedures. There's some images of me doing procedures in the cath lab. I was very busy early in my career for about more than 2 decades, 23 years, doing invasive procedures, device implants, cornea angiograms, and the like. But when I decided to focus a majority of my time on our center, I now have colleagues do these procedures for me. But either way, we'll admit patients and I'll have colleagues perform these procedures. We have very capable colleagues who do a very good job of these procedures. So clinical follow-up is very important. The frequency of office visits is extremely important. It's typical, well, in the United States, it's typical for cardiologists to see patients maybe once a year, maybe every 6 months, or not sooner than 3 months. If you don't need a stent, they may not see you very often. We're different. Obviously, we're treating more than just a cardiovascular disease, but we may have weekly visits. If someone's on a nutritional detox, they may need to see us at least 1 week within the start of the detox, sometimes twice within the week, depending on their condition. The duration may be 4 weeks in the minimum. In a 4-week period of time, we may see someone 3 times or 2 times or whatever the case is. We've had patients come in daily, depending on what kind of treatments they're getting. If they're getting sauna therapy, if they're getting ECV therapy, they're coming in being evaluated by our team with daily and getting these therapies. Food prescriptions and modifications, we're reviewing that with the patients. So we're getting them on the nutritional detoxes. Sometimes they'll do smoothie feasts, and then we'll transition them to solid foods. And then further medication optimization. This is one thing that I'm very, very keen on, is that we wean medication as quickly and as efficiently and of course safely as we can. And so that's really important, really important part of the health. So here's some of our data. We've published our work in medical journals. Here's a defined plant-based diet utilized in outpatient cardiovascular clinic, and it effectively treats hypercholesterolemia, hypertension, and it reduces the medication. So that's an important part. Not all these conditions are getting better, but the medication requirements lower. So we had a population of roughly 31 people. You see the demographics here. And 80% were Black Americans, 3%, 10% were Hispanics, and 10% white. Most had average mean BMI was 37.5, and a pretty good spread across the chronic illness types. Our recruiting criteria, entry criteria, was hypertension, hypercholesterolemia, and increased BMI was a criteria for them coming in. And so here's the food classification system. This is a busy slide, but in essence, in summary, 0 is raw liquid food. So we take some, make a smoothie, a cold pressed juice out of it. It's something that you'll have there. And I'll kind of go through some of the explanation of why I gave the classification the way I did it. The lower numbers are healthier, the higher numbers are least healthy. We don't recommend going past 6. This is plant-based 6. Once you get past 6, you have the animal protein and excessively processed plant protein foods and carbohydrates all up here. So we detox usually from around 0 to 4B, sometimes just 0, sometimes 0 to 3, and it just depends on the condition. But as you can see here, the numbering system simplifies it. Plus, it tells you exactly not only what you're eating, but how it's prepared and where it comes from. So if we look at much of what the patients in this study consume, they had about over an 800% increase, anywhere from 300 to 800% increase in plant foods. And so that was a huge change there. We did not use white potatoes large because it was a raw diet. So that's why this part decreased. Also, fried potatoes went down and all of these processed grains. So if you were imagining putting somebody just on a vegan diet, these numbers would go up a certain amount, but these numbers would also go up, fried potatoes or whatever, if you just say eat vegan. So that's why you have to be precise in terms of what you're recommending. Nuts and seeds, of course, went up. Notice, let's see here. I don't see my, here's my avocado data. So avocado data, they went from baseline 0.1, says an 800% increase in avocado consumption. So keep note of that, because the thing is that oftentimes people say, well, avocado's too high in fat, but it's a healthy fat, and we got benefit when people increase the avocado consumption. So what were some of our findings? Hemoglobin A1C and HSCRP. Hemoglobin A1C decreased significantly, and this was a statistically significant change. So we had about a 3.4% reduction in hemoglobin A1C in just 4 weeks. Now, let me pause and kind of, dig into that for a minute, because a 3.4% reduction in hemoglobin A1C in just 4 weeks, that is about 2 to 3 times the reduction in hemoglobin A1C that you get in prescription, some of the brand prescription pharmaceutical drugs for diabetes, typically. And it takes about maybe 6 weeks, 3 months, no, 6 months. That's the data they typically have when they get, say, about a 1.2 to maybe 1.6% reduction. We had that in just 4 weeks. Now, you'll say, well, wait a minute, hemoglobin A1C is the average blood sugar for 3 months. So how are you seeing a change in that parameter in 1 month when it's a 3-month measure? Well, the other factor that contributes to hemoglobin A1C is blood sugar fluctuations. So if someone's having a lot of wide blood sugar swings, then the hemoglobin A1C will be increased or influenced by just the fluctuation of blood sugar, not just the average blood sugar, the average fasting blood sugar. So oftentimes, my theory is that it's the postprandial blood sugar. So if you're consuming foods, especially animal proteins that are mixed with carbohydrates, you're going to have a high postprandial blood sugar. And it'll come down over time, but after every meal, you're going to have an increased blood sugar, then it comes down, increased blood sugar, then it comes down. So then your actual meals, even if they're on a so-called diabetic diet, may be triggering these high fluctuations. Now, I'll have to, prove that in another study, but that's a very, strong consideration I have, in that the postprandial blood sugars are contributing to a lot of these swings. HSCRP, we saw a 30% reduction in C-reactive protein. Now we've had data for almost 1.5 decades or more of reduction in C-reactive protein. We just published it in this study, but we've been seeing this over the years. So inflammation goes down pretty rapidly. Here are changes in blood pressure. We saw from baseline to the first week, there was a very significant drop in blood pressure, then another drop from week 1 to week 2. But notice from week 2 to week 3, there was kind of a bounce up in blood pressure, and it sort of came down and plateaued, systolic. You see it also with the diastolic, down, down, then up, then kind of back down. And we've seen this also in many patients. We put together data for 200 patients. I analyzed it. We saw the same, down, down, up, and then down. And so something happens around week 3. I don't think patients are calling each other and conspiring to not comply with the diet. I think what's happening is that There's probably some physiological process, a biological process. I think it's a detox process that happens universally around this time, to where maybe toxins are being moved out or the like. And so you may get a transient bump in the blood pressure and it comes down. One could argue that with weaning medications, and maybe medication weaning can contribute to this. And I agree with that being a possibility, but I think there's some biological process that's undergirding this as well. And of course, total cholesterol went down, LDL cholesterol went down. Now, effects on medications. Now, these are total medications from baseline. They were on 2.6 medications on average. Week 1, it went up to 2.7, but overall, it came down to 1.6. And that's those are the blood pressure medications, by the way, not the total medications. So we also looked at inflammatory markers like lipoprotein(a) in this 4-week period of time. And we were the first to show in the medical literature a 16% reduction in lipoprotein(a). Total cholesterol down, LDL cholesterol went down. And these changed all in just 4 weeks. And this is nothing that is, you're not months and what have you, 10 years waiting for something good to happen. This is in 4 weeks. And I would surmise one day we may do a study where we do week-to-week measure of these, but I think a lot of these changes are happening within the first week or two. So we see those changes that are happening significantly. Here's some other biomarkers. I want to point out that LDL cholesterol and Lp(a), these are percentage changes that they're getting. Notice how we get a roughly 6% drop in weight. And then the biological parameters have about a 2 to 3-fold reduction compared to the anthropometric changes. And then when you look at C-reactive protein, it's not on here, but as I said before, that was a 30% drop. So if you look at the biological changes, the changes that are happening at the cellular level, at the tissue level, you see anywhere from a 3 to 6-fold improvement compared to just weight. So, and we've seen consistency among that. Here's the C-reactive protein, 30% reduction. IL-6, inflammatory marker, 23% reduction. Plaque-2, a vascular inflammatory marker. This measure of stability of plaque, the increased risk of heart attack, 16% reduction. So anywhere from about almost 3 to 6-fold reduction in the biological, about at the cellular level, the change we're seeing at the cellular level compared to weight. So when you see someone on this plant-based diet, they may lose a certain amount of weight, you can almost say, well, you're having a 3 to 6 time improvement inside your body biochemically and biologically, which is even greater. So it's really a fantastic thing to know that the body's healing, first and foremost on the inside, before you can really see much of the healing on the outside from the standpoint of at least weight reduction. And of course, white blood cell went down. Now notice we saw again, C-reactive protein is pretty high. Hemoglobin A1C was only 5.9, barely in the pre-diabetes state. And that's one thing I did not point out earlier, is that it was not very high. We did not recruit diabetics. So to see a large C-reactive protein reduction in a very short period of time with this powerful, it shows that the intervention is extremely powerful. And in white blood count, which was 6.3, went to 4.8. Now this, again, was within normal range, but it had a very significant reduction, which means that a lot of people had white blood counts that were normal, but they were not really normal. They were statistically normal, but not biologically normal. And so that's an important difference there. So we did a program for patients with coronavirus, and we talked about the immune system. This is something that really plagued our community. And one thing we really wanted our listeners to do is to really boost their innate immune system. Really, people talk about immunity, and certainly vaccines give you exposure to the antigen and theoretically make antibodies. But even before you get to that point, you have an innate immune system. And if this innate immune system is in tip-top shape, you really don't need exposure. It just knows what's foreign. And if your body's optimally nourished and in biochemical balance, your innate immune system gives you immunity even before you've been exposed to a pathogen. And it takes care of the pathogen. Then the adaptive immune system, after 2 weeks, will then create antibodies and T-cell, B-cell memories for the next time. But the first time you see something that's foreign, you should be able to take care of it. And what we did in this context is that we recommend that people create biochemical balance. And to look at this, you have what's called reactive oxygen species, and antioxidants can help balance this out by donating electrons to these reactive oxygen species. And the antioxidants are plant-based foods. And they work well to prevent to prevent destruction of chronic illnesses and destruction of your tissues. So you like to look at it as in a balance. Reactive oxygen species are necessary because our immune system uses them, but we in a Western diet has an excess number of reactive oxygen species, and that puts us out of balance. So too many reactive oxygen species in our system creates oxidative stress. So more antioxidant brings it in balance. So what's antioxidants? As I said, plant-based foods, but things like grounding, getting away from electronic high EMF formulation. So here you see if you're consuming lots of toxic food and you get exposed to a bacterium, something like coronavirus, that increases oxidative stress. It throws you in, this throws you into further imbalance. And then that puts you at risk for succumbing to an infection. So there's a close relationship to what potentiates these, non-communicable and non-infectious disease as what potentiates the infectious disease, because the immune system, when it's in optimal condition, then it allows you to fight infectious disease very effectively as well. So oxidative stress, the immunity, and here's some things that we recommended for our patients. But coronavirus still is a major issue on the minds of our patients, even now after the pandemic. And so this is something we've had to integrate into our practice, not only in terms of reassuring people that their immune systems are effective, but also giving them lifestyle approaches to help. And so an anti-rich diet. So anyway, we wanted them to stay positive. So let me go through some patients that we had that we managed in our clinic. Here's a gentleman who came to us, and this was the first visit. He had a history of high blood pressure, diabetes. He was on a pretty hefty dose of insulin. He was on metformin. He was on furosemide because he had lots of swelling. He had chest pain, and he was on several medications for blood pressure. When he came into our office, his weight was 284.5 pounds. His BMI was 50, blood pressure 170 over 111, heart rate 122. So I did an evaluation. We felt that based on his heart condition, we should admit him that day. So even though it was our first time seeing him, we admitted him. Here's his 1280 kg. It shows a typical atrial flutter with essentially a 2-to-1 conduction. And so we felt we had to go and be cardioverted at least. Now here is his data. Now some of his data is when we admitted him, and then some goes beyond his hospital admission. I'll sort of walk you through it. But we saw that his GFR, glomerular filtration rate, which is the measure of how well the kidney is filtering. So the higher this number is, the better. The lower this number, the worse. And the creatinine, which is the molecule that we measure GFR with. Now, there's another way of measuring GFR, but creatinine is one way. The higher this number, the worse. The lower this number, the better. Because if you're filtering the kidneys very well, then it filters the creatinine out, and the creatinine level goes down. If you're not filtering the kidneys very well, then the creatinine builds up, and so the creatinine level goes up. So that's a simple way of looking at this. So when he came to see us, his GFR was 20. This to give you some perspective. When the GFR goes below 15 and stays there, that's when they recommend dialysis. So he's very close to being at a point where he would have dialysis recommended. But anyway, he got on our detox regimen. We put him on a smoothie feast, even in the hospital, and his GFR improved pretty significantly, and the creatinine went down. And so we saw these changes initially. Now, people often ask about, well, what about protein? Can you get protein from plant foods? Where does the protein come from? And how are you going to get protein on smoothies? Now, granted, this gentleman came to us. He was eating a standard American diet. In fact, he owned a barbecue restaurant, if I remember correctly. And he was not only eating barbecue, he was eating other things too. But his protein level, the main protein, albumin, was about 1.7. And so this on day one. So we started to detox here. So the protein did not drop. Not only did not drop significantly, but on the detox, it went up. And so it went up to almost 3. And then what happened here is that he was discharged and he went home and he ate something bad. I think he had some chicken soup or oyster soup or something. And his albumin dropped significantly back down to where it was baseline. We put him back on the detox 0 to 4B, and his albumin went up. So on a raw plant-based diet, in this patient, the protein went up. Well, what was going on here? Well, what was going on here was that this gentleman had a systemic inflammatory condition. That's why his kidneys were compromised. He was swelling and he was leaking albumin. So the albumin was low, the protein was leaking out of the bloodstream. So that was because of inflammation. Once he started to detox, as you saw from our data, detox reduces inflammation about 30% in 4 weeks. A lot of that happens within the first week or two. So when we turned off the inflammation, then he was able to maintain protein within his bloodstream, and the albumin went up. When he went back and ate the bad food, he turned inflammation back on, and then the albumin dropped because it's like turning on, pulling the plug from the faucet, things seep out. And so it happened again, and it dropped pretty rapidly. When we went back on detox, we turned inflammation back off, and the albumin went back up. So again, this is what we see with protein. In this patient, he had a greater than 50% medication reduction. There was a correction in his heart rate and the heart rhythm. We converted him to a normal sinus rhythm. His leg swelling went down, improved his albumin level. His overall well-being was improved with this integration. So this whole concept of integrative health, I want to give you a few conceptual slides here to sort of bring it together. And we start off from the standpoint of integrative health starts with the foundation of optimal nutrition. Nutrition is our foundation because it allows for natural healing. You know, we do use target supplementations. We use other modalities, as I said, ozone therapy, et cetera. We use infrared sauna. But we really like to start someone on an optimal nutritional regimen. If someone's doing like that raw detox and following it effectively, they get a great amount of clinical improvement, and it serves to be a powerful foundation to other modalities that you add to help them with healing. Other nutritional interventions are added as needed. So I have a mantra, if you will, maybe you call it the Montgomery Doctrine, whatever, but it's foodaceuticals, is the foundation of your health. Nutraceuticals only as needed. Pharmaceuticals as a last resort. Foodaceuticals is a foundation. Nutraceuticals, that's supplements and other things, only as needed. And pharmaceuticals as a last resort. And so I think if we take that approach, it really helps out in terms of optimizing patients' overall well-being in an efficient manner. So the nutritional intervention, again, fasting and cleansing, we use a lot of that. Whole food detox, education is really important, and also group support groups important with that. It's important that people understand conceptually what they're doing because it helps them go through the process, et cetera. Advanced recipe designs, small group shopping and gardening tools. These are other accessories that we provide on the nutritional side. From a targeted nutrient supplementation side, we do nutrient level testing, microbiome testing. Oftentimes we'll provide intravenous infusion, of course, saline, vitamin C, Myers cocktails, intramuscular sub-Q injections, B12, for example. And then there are all supplements that we may use to assist patients as they transition. Fitness, we have exercise trainers on standby at one of our local gyms. Our patients go and work out. We have exercise prescriptions and things like that. And we try to get them to progress to advanced levels of fitness. We try to get the person who's in the wheelchair to get to walking heels and running heels, because it does not only does them good from a physical standpoint, but it does them good psychologically and mentally, and that improves their overall well-being. We also refer out for things like acupuncture and chiropractic therapy as well. So these are all part of our adjunctive approach. So we like to utilize all these modalities and integrate them, under one roof, if you will. And we try to do this in a way that we can provide some synergy in their effects and synergy in their benefits. Oftentimes, people know to do these things. They may be taking supplements, or they may go and see a chiropractor from time to time, but they're not putting things all together. They're still eating trash food or whatever, and they're getting some relief, but not the optimal relief that they can get. So again, thank you very much for your time and attention. And I think I've left a good amount of time for questions, which is really my favorite part of the presentation, because I really get to hear from you and address questions, because oftentimes it lets me target what people are thinking about. Thank you.
This was some great information, so subscribe to my channel and let's keep the conversation going.